Thank you to the Partnership for Maternal and Child Health of Northern New Jersey and President and CEO Marie Carl for the opportunity to speak with you during your annual meeting today. The Partnership for Maternal and Child Health of Northern New Jersey is a strong and long-standing ally in the health department's work to address maternal and child health issues and a trusted resource for health information for women. At no time was that more important than this past year when pregnant women faced unique challenges during the COVID-19 pandemic. You have been an essential partner in the First Lady's Nurture New Jersey initiative to meet the needs of women and children and to ensure more equitable maternal and infant care and outcomes. We commend you on the work you do every day to improve healthy outcomes for both moms and babes, and especially women of color. We are a wealthy nation, yet our mothers are dying at the highest rate of the developed world. Here at home in New Jersey, we rank 47th out of all 50 states for maternal deaths. And as you know all too well, a Black mother in our state is 7 times more likely than a white mother to die of pregnancy-related complications. And a Black baby is over 3 times more likely than a white baby to die before turning a year old. The health department appreciates your partnership in initiatives like Healthy Women, Healthy Families program, which has enabled countless pregnant women to attend centering pregnancy classes where they can share and learn from the experiences of other women. Your work as a regional grantee of the health department's Expansion Epidemiology and Laboratory Capacity ELC grant is bringing community health workers to vulnerable populations to meet their maternal and child health needs. The apprenticeship training program for community health workers, established through the Colette Lamothe Gillette Community Health Worker Institute, is the best possible tribute to a public health champion and hero and one of New Jersey's finest public health leaders, known to many of you. This past year of the pandemic has been very challenging for all of us, but especially for our most vulnerable residents. We still have much work to do to meet our goal of making New Jersey the safest state in the nation to give birth. But we have to take some big steps, and we have taken some big steps recently, including the planned implicit bias training for clinicians and support staff in maternity hospitals and FQHCs. New Jersey's proposed budget this year again reflects a strong investment in the health of our residents, and it will help us build back from the pandemic while moving our state forward. The department's proposed budget maintains funding to implement implicit bias training in the state's labor and delivery hospitals and programs aimed at reducing Black infant mortality to help improve outcomes for women of color and their infants. In addition, as part of this year's budget, the health department is receiving $450,000 to create a registry for community doulas who provide physical, emotional, and information support to women during labor, birth, and the immediate postpartum period. In recognizing the essential role doulas play as part of an expectant mother's care team, particularly with the additional stress of pregnancy and delivery during a pandemic, the health department issued an executive directive exempting doulas from limits on support persons throughout the mother's hospital stay during the COVID-19 pandemic. We continue to make progress in our fight against COVID-19 and continue working to bring vaccines into our communities, particularly those that are underserved, to make vaccination more accessible to our residents. The educational community Zoom meetings you hosted and other boots on the ground activities helped women get information they needed to protect their families, whether that meant finding a doula to be by their side providing a COVID-19 testing location, or answering questions for those concerned about what impact vaccination would have on their pregnancy, you were there. To date, New Jersey's nearly 1,800 community-based vaccination sites have administered more than 8.7 million vaccine doses, and over 5 million New Jerseyans have been fully vaccinated. But our work is not done. As part of that effort to help keep our state strong, we are counting on all of you as healthcare leaders to encourage all you come in contact with to get vaccinated against COVID-19. All of you are powerful voices in our fight to control this pandemic, and we need you as we race to meet our goal of vaccinating 70% of New Jersey's adults by the end of June. Women in particular, as the healthcare decision makers for their families, can help encourage vaccination for men and now those aged 12 to 15 to help protect them, their families, and their communities. So please, reach out to the men in your lives, your brothers, your fathers, your friends, your husbands, your partners, the women that you know, and the adolescents in your lives and in your work, and talk to them about why it's important that they get vaccinated as soon as possible at one of the 1,800 COVID-19 vaccination sites around the state. As President Biden just outlined in his month of action, and as Governor Murphy and I continue to push, we must do everything we can to ensure individuals, including pregnant women in this state, are fully vaccinated against COVID-19. And we need your help in an all-out push to ensure that we meet our goal of vaccinating 70% of the adult eligible population. I urge you to help us to continue that push, and I thank you in advance for those efforts. So thank you again for all that you do and all that you have done to help all New Jerseyans lead long, healthy lives. Enjoy your meeting, and once again, thank you for all that you do.
Welcome. Welcome. Thank you so much on this beautiful day joining us for our annual general meeting. I'm Marie Colville Ciastolti, President and CEO of the Partnership of Maternal Child for Northern New Jersey. And this is my first annual meeting in this role. So we are thrilled that the Commissioner Persichilli was able to join us on this very important day. She really highlighted the state's significant investment in the health of the residents of New Jersey. She really encapsulated the shared commitment to our commitment to the public health, and she outlined some of the challenges that we face throughout the year. And she also spoke about the work that we did during COVID-19. At the height of the pandemic, we were really the go-to resource for the residents of Northern New Jersey, and we exceeded our expectations for home visitation, education, and outreach. We had a very successful third annual symposium that I hope that you enjoyed and you participated with. And we were recently honored by the Department of Health with top honors, highlighting our work in increasing the flu vaccination in our community and immunization. So what we're doing today with our annual meeting is really renewing our commitment, our unwavering commitment to improving the health and wellness of women, children, and families within Northern New Jersey. So if this is your very first annual meeting with us, welcome and thank you. If this is not your first annual meeting and you're a longtime supporter, thank you for the support and welcome back. So we appreciate the opportunity to share with you the impact that we've had in Northern New Jersey and share with you also our vision for the future. So who are we and what do we cover? We are a 501(c) organization licensed by the Department of Health to improve the lives of women, children, and families within Northern New Jersey. We are one of 3 consortiums working together for that common goal. Within our region, We cover 4.5 million people within our 8 counties. And we have the distinct honor of having 4 of the largest cities within the state, largest and most diverse, which are Newark, Jersey City, Patterson, and Elizabeth. So while the work that we do on a daily basis may not be visual and to the public, we serve over 30,000 residents in New Jersey. So here you see our region, you see our map, the 8 counties that we cover here. We work closely with our hospitals and our birthing centers to identify unique challenges that they face. Whether you're located in a very densely populated urban environment, suburban communities, or rural areas, we are working together to achieve the common goal, to provide high quality healthcare for all people. So looking at the work that we do, we use data, working in conjunction with the Department of Health and our healthcare information hubs to center equity. Because we know that centering equity is the core of quality initiatives. Equity must be realized if we're going to change the paradigm, if we're going to transform the existing paradigms that we have now and change the narrative. Our commitment is at the focus of everything that we do. It is our guiding light, our North Star. We have over 40 programs, and our staff of 130 people keep this on the frontal lobe on a daily basis. So our commitments are centering the work that we do around supporting pregnancy and parenthood, engaging communities, empowering communities, advocating for change, and we cannot forget engaging healthcare workers and providers. So for nearly 3 decades, we have worked to improve the lives of women and children, improving maternal child health and outcomes in New Jersey. How do we do this? By protecting, serving, and providing direct care and support to ensure healthy families, healthy pregnancies, and the tools that they need, resources that they need to make sure that the mother, child, and family are thriving. We work hard with parents, knowing that pregnancy is only the beginning of the work that we do. We give parents the tools and resources and access to learn parenting skills and to train for the future. So with the increasing challenges of COVID-19 during the past year, we make sure that we bond with our community members, with our residents. We form intimate bonds and trust, so much so that during this year, one of our community health workers gained the trust of one of our patients. And during telehealth, which is extremely important to gain that trust and connectedness, she got her client to share with her that she was being molested by a family member. Her and her younger sister were being molested. She was only 14 years old. So we worked really hard to ensure that the authorities were involved, that the family was safe, and that we brought her and her sister into a safe environment to be able to thrive. So the work that we do supports families mentally, physically, emotionally to ensure the well-being of their families and their communities. Empowering communities is so important to the crux of the work that we do. Here you see a picture of the Morris Family Success Center. Their volunteers are diligent in working every day, from homework help to finding resources to thread the community together. So many of the programs that we do in our Morris County Success Centers and our Irvington Success Centers center on protecting, serving, empowering, from adolescent and teen outreach to parenting skills, vaccination, nutrition, lead poisoning, and so much more. We connect other nonprofit organizations and make sure that our community action boards are supported and strong. But we know that none of this can be done without the professionals that help us on a daily basis being the go-to resource. Nothing can be done without our physicians, nurses, social workers, doulas, and other healthcare providers. We enlist national and international expert speakers to share best practices within our networks to provide a variety of topics, from IVF support, COVID-19 vaccinations, healthcare proxies, human trafficking information, grieving and depression for fathers are only just a few of the topics that we engage our healthcare professionals with. So we are the voice of families when they are not at the table. We ensure that patient-family care, patient-family support is at the table and within our local healthcare centers. We advocate for our communities, ensuring that equity is at the table. And we know that equity is not equality. So we advocate for change. The racial disparities that our commissioner spoke about are deeply disturbing and unacceptable. So as advocates, something that we do on a daily basis is that we enlist thought leaders, community advocates, and key decision makers to fight for real, sustainable change. We are making our voices heard, loud and clear and abounding, that when we advocate for patients, we are advocating for increased access to LARCs, to increase pregnancy interventions, reforming postpartum care and postpartum access and postpartum coverage, establishing implicit bias testing, access to mental health providers, and aligning with our systems and our collaborative networks to ensure streamlined process and decrease redundancies. So I know that I've only scratched the surface of the things that we do in this couple of minutes and the way that we enhance the lives of those that we serve. But we have an opportunity here to be disruptors, to forego the status quo and to reframe the narrative. The possibilities that we have are endless, to expand our reach, to strengthen our communities, and to fortify our partnership with your help and collaboration. So I am asking you today to join me in making that impact. When you leave this process today, I'm asking you to tell somebody about the partnership, direct them to our website, refer someone in need to us. We are there 100% of the time. You can go the extra mile, you can donate, you can join our gala, you can do so many different efforts to ensure that the community at large is moving to a changed paradigm, that our mission and our vision are clear, that we are changing and saving lives. So you've heard a little from me. I want to share with you a quick video of voices from staff in our community about the value of our mission and our vision. thank you. We look forward to your partnership in enhancing the lives of women, children, and their families. So I would like to introduce Dr. Michael Lamacchia, Chairman of the Board for the partnership. He is also the Chair of Pediatrics at St. Joe's Hospital. Dr. Lamacchia has been a longtime supporter, very dedicated to the mission and vision of the Partnership of Northern New Jersey, working tirelessly to advance and enhance the lives of the women and children and families that we serve. Thank you, Dr. Lamacchia, for your dedication and all of your hard work and of your guidance. Thank you so much, Dr. Michael Lamacchia. Oh, I think we may be having a little technical difficulties. Okay, so we'll have Dr. Wendy Warren, Chair of the Nominating Committee, start with our slate and give us some information about our nominees. Wendy?
Thank you, Marie Carl. You can hear me okay, right?
I can.
Thank you. So welcome to our general members and the members of our Board of Trustees. As chair of the nominating committee, I'm going to present to you several new, a little bit of feedback, but anyway, a few new general members. And then we will present the slate of officers, sorry, the slate of trustees, our slate of trustees for the board. So our general members support our organization, contribute to our committees, and are an important resource for the leadership team at the partnership. We have two new general members that I would like to introduce to you. And just a shout out to the other members of the nominating committee, Rochelle Evans and Mary Mateague, who have been tireless in getting together remotely this year. Dr. Davina Lopez is a board certified pediatrician who is field doctor for the Bureau of School Health, SH Medical, in New York City Department of Health and Mental Hygiene. In her resume, Dr. Lopez says that she's driven to communicate well and establish strong rapport with her patients. She enjoys teaching and is always enthusiastic to share her unique approach to caring for children. Then our second new general member is Ms. Irina Lomaga Carey. Ms. Carey is a partner in the real estate department of Kurzman, Eisenberg, Corbin, and Lever. Her practice focuses on commercial real estate transactions, including commercial sales and acquisitions, among many other experiences. Ms. Carey has represented landlords and tenants in enclosed malls, strip centers, warehouses, and many other real estate locations. She has extensive experience handling due diligence in connection to significant real estate acquisitions. Ms. Carey is active in her local community, serving as a trustee on various service organizations and educational institutions. So welcome Dr. Lopez and Ms. Carey as our new general members. Moving on to our Board of Trustees. The Board of Trustees is the leadership body which oversees and provides guidance for the Partnership for Maternal Child Health of Northern New Jersey. By New Jersey's statutes which established the Maternal Child Health Consortia, our board is made up of three groups. 1/3 are nominated by our member hospitals, 1/3 are healthcare providers, and 1/3 are what we call consumers who bring a wealth of knowledge to our organization outside the medical fields. At this time, we welcome the new board members who have recently been nominated to serve by their hospitals. Margaret Fagoralek has been nominated as board member and representative for Valley Hospital in Ridgewood, New Jersey. Ms. Fagoralek is Director of Care Coordination and Women's and Children's Services at Valley Hospital in Ridgewood. Our second new board member nominated by a hospital is Ms. Ingrid Bruce. Ms. Bruce has been nominated as representative on our board for the University Hospital in Newark. Ms. Bruce is Assistant Director of Nursing for Maternal and Child Health. Welcome to our new hospital appointed board members, Ms. Fogorelek and Ms. Bruce. In addition to our slate of returning board members, the nominating committee has proposed a new board member, Ebony Riley, Esquire. Ebony Riley is currently Associate Counsel of St. Joseph's Health in Paterson, New Jersey. She was born and raised in Paterson. She obtained her Bachelor's of Arts in English from Rutgers University in New Brunswick and her Juris Doctorate from Seton Hall University Law in 2009. She is admitted to practice in New York, New Jersey, and the United States District Court for the District of New Jersey. Prior to joining St. Joseph's, Ms. Riley was General Counsel and Chief Operating Officer of a New York-based medical practice and a former insurance defense litigation associate. Her hobbies include volunteering for church and community, playing basketball, traveling, watching the New York Giants football, and spending time with her family. Of course, I have a family of Jets fans, but we'll forgive her. When asked what drove her to become an attorney, Ms. Riley will tell you that she always had a passion for proving a point. She wanted to be able to provide a better life for her mother, who raised her and her twin sister as a single parent. While Ebony lost her mother to cancer 3 months before graduating from law school and 6 months before taking the bar exam, she remained determined to excel, noting that her mother was her drive, and upholding her legacy continues to drive her today. So on your screen, please see the slate of board nominees, including our trustees who are up for reappointment, as well as Ms. Riley. The general members of the partnership are tasked with voting for the Board of Trustees. Our members are now asked to vote for the slate of trustees. Please find the area on the screen and register your vote. And in the meantime, I'm going to just read the list of our board members who are up for reappointment. If I can get my screen to work. Lillian Camacho from St. Mary's General Hospital, Charles Kasser from Valley Bank, Marilyn Cintron from the Alliance Community Healthcare, Valerie French from Englewood Health, Lisa Gittin-Williams, MD, from Rutgers, New Jersey Medical School, Dr. Lamacchia from St. Joseph's University Medical Center, Deborah Murray from Jersey City WIC Advocate, Dr. Michelle Preninger, who's associated with Women's Emotional Wellness Center, Elaine Rule for the Center of Family Resources, Anna Stepnowski from Hackensack Meridian Health Palisades Medical Center, Linda Tantawi from Lustgarten Foundation, and myself from New Jersey Perinatal Associates. So please cast your votes. And I think we need a few more minutes. And so I would just like to remind all of our trustees that in agreeing to be members of our Board of Trustees, the board members agree to the following duties: the duty of care and support for our executive management team and our staff, as well as fiduciary responsibility of overseeing and supporting the funding of our organization. The duty of loyalty, agreeing to make decisions in the best interest of the organization. And duty of obedience, agreeing to follow our bylaws and guide the partnership according to its mission in improving maternal and child health in Northern New Jersey. Is our vote completed?
Yes, the vote is complete.
And
We have 99% agree, so we are all set.
If we were in person, I would have all of our board members stand to applause, so we can all just applaud them, I guess, on screen. But congratulations to our returning and our new our new board members. Thank you very much, everybody, for all of your participation and all of your loyalty. I would now like to turn our meeting over to Dr. Liliana Panetta, MD, MPH. Dr. Panetta is our Chief Operating Officer of the partnership and will introduce our speaker. Dr. Panetta.
Good morning. Welcome to today's webinars and thank you for joining us. My name is Liliana Pinetta. I'm the Chief Operating Officer for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our presentation is titled Understanding Trauma and Ways of Healing. I would like to give you some information before we get started. After the presentation, you'll receive an email with a link to a post-program evaluation. Please complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the Partnership YouTube channel. We will be muting all attendees' mics during the presentation, but we would love to hear from you. Please write questions in the question box and the speaker will respond to as many as possible at the conclusion of the presentation. Now I have the privilege to introduce today's speaker. I met Dr. Joshua Sparrow about 2 months ago, but I feel I have known him for many years. In my careers as a public health professional and mom, I have read all the books Dr. Sparrow co-wrote with Dr. T. Barry Brazelton. And I still keep them around just in case I need to discipline my son the Brazelton way. Dr. Joshua Sparrow is the Executive Director of the Brazelton Touchpoints Center in the Division of Developmental Medicine at Boston Children's Hospital, where he also holds an appointment in the Department of Psychiatry. Dr. Sparrow cared in the 1990s for children hospitalized for severe psychiatric disturbances, often associated with physical and sexual abuse, prompted his interest in the social determinants of health, community-based prevention, and health promotion. He is a principal investigator on numerous foundation grants and has lectured nationally and internationally, written numerous papers, as well as books and articles for the general public. He has advised government agencies, nonprofits, and philanthropies. He is a board member of the Parents as Teachers and serves on the advisory boards of the Association for State and Tribal Home Visiting Initiative and Rapid Response Virtual Home Visiting. At the Brazelton Touchpoints Center, his work focuses on cultural adaptations of family support program, organizational professional development, and aligning systems of care with community strengths and priorities. Examples include collaborative consultations with the Harlem Children's Zone and tribal early Head Start programs, among others. Brazelton Touchpoints Center provides professional and leadership development, organizational learning and change, research and evaluation for family-facing professionals in pediatrics, early childhood, infant mental health, home visiting, and child welfare. Brazelton Touchpoints Center is home to the Touchpoints approach, the Brazelton Institute, Family Connections, and the Brazelton Touchpoints Research and Evaluation Team. Please visit their website at brazeltontouchpoints.org. Dr. Sparrow, welcome. We are all very excited to hear your presentation.
Thank you so much, Dr. Panetti, and thank you everyone at the partnership for bringing us all together today. I only wish that I could be there with you, to be with you and to meet you all. As Dr. Panetti mentioned, I first got interested in trauma professionally back in the 1990s when I was involved in the care of about 3,000 children. 75 or 80% of them, all hospitalized on our inpatient unit at Boston Children's Hospital, had been physically and or sexually abused. And I became concerned about a number of things. One, that so much of their suffering was preventable and completely avoidable. And also that our systems seem to subject them to more abuse and more neglect after what they'd already experienced. So that's why I ended up partnering with Dr. Brazelton to move upstream and begin the work earlier. Today, though, we're still in the midst of a multi-pronged crisis producing trauma for so many of us and those we care for. And so I'm going to focus today on understanding trauma and ways of healing. And before I begin, I need to let you know that the planners and speakers, that means me, have no financial disclosures to make. That approval status does not imply endorsement by the partnership, and also that in order to receive continuing education hours, you'll need to attend the entire webinar and complete an online evaluation. I'm hoping that at the end of our time together, you'll be able to define trauma and distinguish traumatic events or experiences from trauma effects. Those are the 3 E's. To identify differentiating characteristics of trauma that contribute to variations in effects and how these apply to COVID-related trauma. And finally, to be able to explain approaches to healing to our own self-care and wellness as providers, to explain approaches to resilience, as well as to explain individual, family, and community level protective factors. So I wanted to just start by offering this trigger warning. I am not planning on speaking about specific traumatic experiences or events in graphic detail, but I will list a number of examples. And many of us who have experienced trauma in our own lives before this past year, and many of us during this past year, people who are doing frontline primary care have been overwhelmed by the pain and suffering and death that they've been exposed to. And so if at any time you need to break away or stop listening or focus on something else or decide what you're going to do for the rest of the day to pull yourself back together again, I just wanted to let you know we're going to be talking about trauma today, and thinking about trauma can bring up prior experiences of trauma and the feelings that go with them. So here are the things that I'm going to try to cover. We'll go into some definitions just so that we're all on the same page. And then, as I mentioned for the first objective, just to be clear, when we talk about trauma, that we're distinguishing events, experiences, and effects, as often those get confused, and to talk about triggers. Then I'll want to talk about variables in both the events and experiences and in individuals and their contexts that can influence the effects of these traumatic events, experiences, and those include risk and protective factors. And then I'm going to try to touch on COVID-related trauma to the extent that we have some sense of what that is looking like, although that we're still in the midst of it and the literature is still very early on. And then finally, I'll talk about healing and resilience and ways that we can support healing. And I wanted to mention there that another reason why I got interested in this professionally, and many of us also, are interested in this personally, because trauma is so pervasive. And for example, it's estimated that 3 out of 4 girls have been sexually abused, and 1 out of 6 boys have been sexually abused. So it's very common. But one of the other reasons why I got interested was I thought that in our work with children who've been physically or sexually abused, we put them in therapy and we put them in sort of formal clinical treatment, and I became concerned that they ended up really hunkering down around their identity as patients, or their identity as defined by the traumatic experience. And I began to wonder about whether or not that was always helpful, or whether or not we were missing other ways of supporting their healing. And not that long ago, just before the pandemic, a 15-year-old who was on the inpatient unit, where I still go regularly to teach the medical students, said to me, and she had a terrible history of sexual abuse. She said to me and to the medical students, you know, it doesn't help when you people look at me like I have damage etched into my forehead. And that was really what I became concerned about, was that we, while trying to, you know, help children, quote unquote, process the trauma, maybe without meaning to, of course, interfered with the strengthening of the other aspects of their identity, which ultimately would be how they would heal. So to start with definitions, and here I'm looking at the American Psychiatric Association, and people have proposed others before and since, but I think this is a simple and clear one: the direct experience of or of witnessing events in which there is actual or threatened death, serious injury, or violence. Trauma occurs when frightening events or situations overwhelm a child's or ability to cope or deal with what has happened. So here are some examples, and you know, these are no surprise to any of us: natural and human-made disasters, serious car accidents, which are common, physical or sexual abuse, also common, and domestic violence. And as I said, you know, there's continued conversation about how we define trauma. So some are extending the definition to include any stressful event that significantly impairs the person's daily functioning, for example, at work or in personal relationships. And that can get blurry, but just to say that that is one direction that this conversation is going in. So trauma, the word trauma is also used to describe several different kinds of trauma. And one is the event that I just laid out for you that threatens safety and survival. That's usually extraordinary, something that humans don't typically experience. Another is recurrent ongoing threats to safety and survival. And these different kinds then have different effects as well. Then there's vicarious trauma. And vicarious trauma is something that many of us in healthcare experience as we listen to and bear witness to the traumatic experiences of the children and families, individuals that we provide treatment for. And the secondary trauma is sometimes used interchangeably with vicarious trauma, but is also being considered as actually a kind of form of post-traumatic stress disorder that results from vicarious trauma, from bearing witness, from listening to over time. Then, and this may or may not really qualify as trauma, there's burnout, compassion fatigue, and moral injury. And those all can happen, though, in the course of bearing witness to the trauma of the patients that we care for. And moral injury is, as I understand it, this idea that we know what needs to be done to prevent or to reduce suffering or to promote healing, but it's beyond our power. It's not within our resources to bring about what we know needs to be done. And so typically moral injury occurs when there are social determinants of health, when there are concrete material needs that are drastically interfering with our patients' health and well-being, and we know they just need a roof over their heads or they just need food on the table, but it's not something we can write for on our prescription pads. Then there's racism-induced trauma, also being referred to as racialized trauma, which also is all too common and for so many a daily, multiple times a day experience. And then there's historical trauma, also called intergenerational trauma, and I will come back to those briefly later on. The idea of historical trauma, I think, first appeared in the literature regarding the Nazi Holocaust of World War II, but it's been applied. It was applied subsequently in the 1990s by Maria Braveheart Yellowhorse regarding the Native American genocide in this country, and it has also been used with regard to the experience of people brought over from Africa as slaves and the transmission of that trauma over generations to their descendants. So the 3 E's are from SAMHSA, and as I mentioned before, We're going to carefully distinguish them. Often when you see the word trauma, it's not clear which we're referring to, but I'll try to talk about traumatic events and experiences, which refer to what happened. And traumatic effects are the resulting thoughts, feelings, behaviors, or changes in relationships. And here's what SAMHSA says in more detail. Individual trauma results from an event, a series of events, or a set of circumstances that are experienced as physically or emotionally harmful or life-threatening, and that have lasting adverse effects on an individual's functioning and mental, physical, social, emotional, or spiritual well-being. And that's from SAMHSA 2014. It's their document on trauma-informed care. So here are some factors that influence the effects of traumatic events experience, and they're basically what, when, where, and who. We'll get to who next. So what? And as you're trying to assess and anticipate the extent of the effects of trauma, to ask what, when, where, and who can be very helpful. So the what is severity of the event, of the resulting harm from the event itself, and the resulting long-lasting disruptions. And you beginning to see how you can think about COVID-19 or the murder of George Floyd or 9/11 as having similarities and really important differences in terms of what the what was. When, when for the individual, how old was the individual when it occurred, and how often did it happen more than once, and how long did it go on for? And then there's where, and basically it's about proximity to the trauma. Dr. Brazelton, who Dr. Panetti mentioned earlier, and I worked in New York after 9/11, and I remember going to a high school that was right across the street from Ground Zero, and there was a mother who said that her daughter really didn't seem to have any significant effects from the destruction of the two towers that occurred right across the street. But she noted that although she was doing really well academically in all of her courses, there was one course that she was really struggling in, and that was her Spanish class. Well, guess when and where her Spanish class happened? That class was in a classroom that looked out on the towers, and that class was at 9 o'clock Tuesday morning when the towers came down. And so you can imagine every time she went back to that classroom that she dissociated. She had to sort of leave her body and leave the space she was in because she couldn't bear to be there. And then there's the who. We said what, when, where, and who. And so there's both who the trauma has happened to and who may have been involved. In terms of the individual experiences of trauma, personal characteristics, temperament, as well as prior mental health challenges. Although it's trickier than it seems, because in the context of COVID-19, we've been hearing a lot about how extensive the negative impacts for mental health and learning have been for children over the course of this past year plus now. And yet, there have been some studies that have shown that some children with prior mental health challenges are actually doing better and feeling better because they were more stressed by being in school than they've been during the pandemic while being at home. Previous traumatic events for the individual who's experiencing another one. And then there's the who was around during this event. Who stopped the event? Was there anyone who helped? If something, if one experiences trauma, was there this sense that there was no one to tell, that no one would believe us, or that we would be made to feel like it was our fault? And if we did tell, did others believe us? Did they seem to care? Did they seem to recognize the depths of our experience of it? And if the traumatic event was caused by another person, and I'm thinking obviously of physical or sexual abuse, was it a stranger? Was it someone familiar? Was it someone who was thought to be trustworthy? Someone whose role, and this is for children in particular, but not only, someone who was supposed to give care or protect. So what, when, where, and who regarding traumatic events really influence their effects. And here are a few ways trauma hurts and places to look: mental health, obviously, academic and work performance. And I just gave you an example of that girl in her Spanish learning, relationships. And one of the things I want to point out about relationships is when the trauma is interpersonal, and we just talked about the who, when it's inflicted, for example, by someone who is in a caregiving role, who is meant to be trustworthy, but who then doesn't behave that way, it can have lasting effects with regard to the individual's ability to trust others in intimate relationships, and can make it harder to enter into and stay consistently in intimate relationships. And then there's family functioning, and again, the effects of trauma for family functioning will vary if the traumatic event was experienced by one family member and caused by another, or if the family together experienced the traumatic event. And then there's health. And here, you know, you're all familiar with the And and Felitti research done back in the 1990s on, along with Robert Sapolsky's work on the effects of stress and Bruce McEwen's work on the effects of stress, that's shown that severe trauma, and particularly severe chronic trauma, can have lasting negative impacts on lifespan longevity, not just on mental health, but on physical health as well, particularly cardiovascular, metabolic, etc. So here are a few ways that you'll see trauma in your clinics, and there are developmental variations for these. I mentioned withdrawal, and withdrawal you can think of as the child or adolescent or adult trying to do the best that they can, and they're protecting themselves by pulling away, maybe from everything, if that's the best they can do, or from whatever they associate with where there may be a danger. Trauma can also have, traumatic events can also be effective disrupting mood regulation and lead to mood swings and irritability. And I mentioned mistrust, disrupted attention and concentration. I think you heard in my story about the girl in her Spanish class that she could not attend or concentrate because she was really dissociated, numbed somewhere else. And sometimes traumatic events can disrupt attention because there are these repeated memories, these sort of intrusive memories or flashbacks of what happened that make it very difficult to focus on what's going on right here and now. Another pathway that interferes with academic functioning. There can be repetitive risk-seeking behaviors, and often you see this in children or adolescents who've been sexually abused, that they may engage in risky sexual behavior as a kind of repetition compulsion, as a way of maybe trying to find the abuser if in fact they were so young that they know they were abused but don't really have a good sense of who, when, or how, or as a way of maladaptively, but it's the best they can do, trying to get a sense of control and mastery. Because one of the hallmarks of traumatic events and experiences is the sense of violation, of having control and power over oneself, one's body being taken away. And then alcohol and substance use disorders or other effects. And in our current opioid epidemic, the literature is showing that at least 60% of women of childbearing age have experienced physical or sexual abuse, and many have post-traumatic stress disorder as well as other mental health conditions. And then, as I mentioned, there are these long-term lifespan health concerns, and studies have also shown that telomeres are shortened, and this also is, one of the many aspects of racial health inequities and the effects of racism on health. So we've seen telomere shortening in people in general who've experienced severe chronic trauma, but we also see telomere shortening in African American adults, and it is thought that this is the result of chronic exposure to racialized trauma. So here are examples of triggers, and a trauma trigger is anything that brings back the thoughts or feelings or memories, intrusive memories or flashbacks. So it could be the person who caused the trauma, or just someone who has a voice like that person or is the same size as that person, or the place that it happened, or a place like the place where it happened. It can be the time of the year when it did happen, or it can be at times when families come together, if this was something that happened within a family. It can even be certain kinds of weather that really feel like the way it felt the day this thing happened. Certainly, many people will resonate with songs or films or novels as triggers for trauma, where the content stimulates those thoughts and feelings. And then separations, losses, or new traumatic experiences bring back the memories of old trauma. And separations and losses, Lord knows we've been through so many over this past year, can bring back memories of old trauma, because for many kinds of trauma, one of the feelings was, I was all alone and no one knew, or no one was there to protect me, or I couldn't get to anyone. So the loss of someone in a nurturing or caregiving or loving role can also bring back memories of a prior trauma. And then raising a child can have moments of traumatic triggers if, for example, the adult experienced sexual abuse at age 6 or age 11. When their child is at that age, they may feel more intense memories and thoughts, and it also can affect their parenting in terms of struggling with, how do I protect my child from ever going through what I went through? And then there are racist statements or acts, which are each and every one of them are instances of traumatic events or experiences, and each one can layer on top of and bring back memories and thoughts of all of the prior ones of that same day, of yesterday, of last year, of years ago, and historical ones as well. So here are some of the things that happen to us when we are affected by a trauma trigger. There are flashbacks, as I mentioned, where you really can see and hear and feel a traumatic event happening again, and it's a physical feeling. Panic attacks may go along with that. I mentioned dissociation, which is this kind of leaving of the body and of the moment in reality as if it was the only way to cope with something that's intolerable. There's also not being able to judge the extent of current danger. So when, for example, a trauma trigger is that man who has the body shape and the voice like the man who did that thing to me, I don't know whether or not this man is actually, going to do that to me, or if this is just, some guy who's okay. So it interferes with those kinds of judgments, and you can see how that can then really interfere with entering into and sustaining relationships, whether they're friendships or other kinds of intimate relationships. And then there can be retreating into thoughts about the trauma, preoccupation, really cycling the memories over and over again, which interferes with focusing, as I mentioned. And then there can be this urge to blurt out what happened. And, one of the burdens of trauma is the silence. It's the secrets, the nobody knows but me, and I don't dare tell because they'll blame me They won't believe me. They won't understand how it made me feel. They may not care, and they may minimize it. And this, I think it's really important also to remember in the context of racialized abuse, where for people who have never experienced racialized abuse, and I'm thinking primarily of white people in white majority societies, it's a very intentional developmental process over time to get to the place of really being able to just be quiet and present and listen and open to exactly what the experience was for the person who experienced the racialized abuse. And I personally don't think that we ever can know what it's like to be anyone else, but I think we can try. And I think that takes sort of getting ourselves out of the way, a lot of humility, and really opening up space. And I think readiness to accept your own responsibility. Another effect is feeling like disappearing or rushing away. So if a trauma trigger really brings back the feelings of it's happening again, to just take off. And I remember once a long time ago when I was in training, I had an adolescent boy in my office who had found his mother after a suicide attempt that was very serious. And being young and even more foolish than I am now, I brought that up, and he ran out of my office. And he taught me a lesson, which was just talking about what happened is unbearable, and I got to get out of here because it feels like it's happening all over again. And then there's pulling away from others in an emotional sense, and then rejecting help when we need it, because trauma can make it difficult to trust. And you can think about this in the context of many different kinds of trauma. So when we're looking at trauma effects and what people need to heal, we can think about the what, where, when, and who. And when we think about the who, we can think about what were the pre-existing individual, family, and community challenges, as well as strengths, supports, and protective factors. And then over this past year, we can think about what were the ongoing individual, family, and community level strengths, supports, and protective factors, as well as challenges. And I've talked about some manifestations of trauma and trauma triggers, and I'll talk a little bit about what the literature is saying at this point about COVID-19 effects, although, as I said, it's still very early on as far as the literature goes. So we talked about the where, and so we can take that to the COVID context. How close to COVID-related trauma is the experience of serious illness, of separation for self-quarantining, hospitalization, or death? How close have those experiences been? And this is where healthcare providers are at such great risk for trauma. And then there are the related disruptions due to COVID-19, job or housing loss, food insecurity for children, family members living with family members who are primary caregivers for themselves, but are also essential workers like healthcare workers who are at increased risk of infection. This has shifted with vaccination, where there may be, a far greater sense of reassurance, but people still, have that prior experience of fear that they may still be carrying. Then there's, parental stress when we're thinking about families and children due to the whole host of disruptions related to this pandemic. And then it has been, I think, traumatizing once again to see so clearly what's always been there in terms of the racially disproportionate health and economic inequities, racially disproportionate health access and outcomes. And then the politicization of COVID-19 that we've seen over the past 12 plus months, the scapegoating, the erosion of trust, has also, I think, been traumatizing. And, you know, in what I said earlier, I think you can see how trust is so vulnerable to trauma. And when there's all of this political struggle over how serious it is, do we use masks, does social distancing make sense, how do we balance that with the effects on the economy, are vaccinations safe, how if we lose the sense that we can't trust these institutions that we've had to count on, how that can also make us more vulnerable to trauma effects. So this also is not news to anyone, but we've seen over this past year plus disrupted relationships to primary caregivers, and that includes grandparents who are isolating now. Hopefully many of them have been vaccinated and that's better, but the residue may still be there. There also was the separation from teachers and from mental health providers. And then, you know, there has been concern about the effects of masks and social distancing on children, especially under age 4, where they're really developmentally in need of this face-to-face stimulation, interaction to understand the expression of emotions, which is such an essential part of communication. And then there have been disruptions in the way families operate. And again, the literature has been somewhat mixed. You know, there was probably more literature showing greater parts of the population negatively impacted, but there are some smaller groups where there's some sense that there have been some positives for the reconfiguring of the way families have been operating, although there's enormous variation there, with many families not having the luxury of being able to work at home, and many families also dealing together with all kinds of other stresses, either prior that existed prior to the pandemic, or that have resulted from the pandemic and its effect on the economy. So, you know, as you're looking at individuals and families who you're wondering about effects of trauma, it's important to look at pre-existing challenges, and I wanted to highlight the structural challenges related to race or socioeconomic or immigration status, and all of those were drastically exacerbated over this past year, but they are centuries old for so many. And then there are, you know, situational challenges which are highly variable in terms of the structure of families and the availability of supportive relationships, and to what extent the availability was compromised by quarantining or social distancing or lack of access to digital communications. And then there were pre-existing mental health and other vulnerabilities, although, as I said, there is a group of children who that's not insignificant. There's one study out of the UK that said something like 50% of kids were saying this has really made their lives much harder and worse, but about 25% of them said this is actually, you know, better than it was. And that group tend to be kids who had negative experiences prior to the pandemic in school, sometimes because of their developmental or mental health challenges that were not well served in traditional school settings, and sometimes because of their experiences of racism in their school settings. So there are also pre-existing supports and protective factors that are important to take into account. And of course, concrete material resources were disrupted for some, but not all. Resilience is something that people construct over time, and it is not solid state, it evolves, but for many was built long before this crisis, because people have had to find ways of adapting to all kinds of other stressors long before. Then the quality of relationships can't be overemphasized in terms of their ability to protect from the most serious effects of trauma. And then there are cultural traditions that cultures have elaborated over generations, over centuries, over millennia, because people have had various kinds of struggles over history, and cultures come together to figure out how do we survive and come back together again and thrive. And so cultural traditions also, when there's access to them, really important pre-existing protective factor. And then their spirituality, which we rarely talk about in the health and mental health world. And yet I have to say, every time I bring it up, people are always grateful for it, because for so many of us, regardless of the form our spirituality takes, it is central to the way in which we heal. And I should say, when I talked about the things I thought we left out while we were treating children with trauma, those are some examples. The healing within cultural traditions and within spirituality. And here are some other community level strengths, supports, predictive factors that I pulled out, because you can see how some of them were disrupted in some cases over the course of the pandemic, in part because we didn't yet have the scientific understanding that we now have. If you think back to February or March of 2020 or June of 2020, and it continues to be a moving target, and in part because of the politicization, and in part because of the way that social media has really taken down our ability to trust many information sources. So, but when we have reliable information from sources we trust, that's a protective factor. When there's a consistent, predictable, clear communication about unknowns, uncertainties, or dangers, where we're just level and are honest, this is what we're not sure about, this is what the science has not yet established, that also can be a protective factor. And then an acknowledgement and acceptance of the full range of emotional responses, of the fear, of the anger, of the frustration, is really important in protecting against some of the mental health impacts of trauma. And having to shut them down or hide them or be silent about them is a big risk factor. And then recognizing and appreciating the strengths that folks summon up to cope with these challenges, not just the strengths, but the recognition and honoring of them and the value of them is an important predictive factor. And then when we're talking about families, adults, and children, adults modeling resourcefulness and effective handling of emotions and unknowns, which includes handling emotions of frustration or anger or fear, modeling those is also a source of protection for children. And then having a sense of purpose, value, and opportunity to help is really important. I have a patient who was really struggling and then started making masks. And I think she probably made something like 1,500 masks or something. And while she was making masks and concentrating on the manual, putting them together, but knowing that she was going to be saving people's lives, was enormously protective for her. And then there's self-care, which I can't emphasize enough for all of us who are healthcare providers. And often I think we fail to recognize the importance of our own creativity and our need to express it and use it. And I think for many humans, and this doesn't get talked about all that much, we have this fundamental need to be able to be creative. And it doesn't mean we have to be great artists, but we got to make things. And that might mean something very simple that no one else wants to see or hear, but we have to express ourselves in creative ways. And then there are the others, which do get mentioned far more often, of healthy nutrition, physical activities, exercise, mindfulness, and spiritual practices. So here are more protective factors. Glad that there are so many. It helps children to see when adults are taking safety measures that they can believe in. And so in communities where there has been less struggle about masking and social distancing, that's been really reassuring for children. And then seeing fairness modeled has been really important for children. So you can see how when children are confronted with the racial inequities that lead to their family members, their neighbors, their friends getting more sick more often, more seriously ill, with more deaths in their families, how terribly disruptive that is. And then especially children, but adults too, having the ability to trust in a collective commitment for mutual caring, which has really been centered by the pandemic, because when we vaccinate ourselves or wear masks ourselves, we have been taking care not just of ourselves, but of others. And it's not that we go around showing that off, But when that kind of commitment, not just to our own well-being, but to that of others, is visible, it also is a protective factor at the community level. And then we talked about cultural traditions, but I wanted to add cultural traditions that help us make sense, help us tell the story of what has happened in ways that give us positive possibilities for the future. So you may want to stop and ask yourselves where you're seeing trauma in yourselves, in your families, in your neighborhoods, in your work, in the patients that you serve, in your institutions, and what does it look like to you? Does it look like some of the things that I've tried to touch on? And when you look for where trauma is, we talked about how it manifests with some developmental variations in behavior in different areas of functioning, but I wanted to be sure that we also talked about some of these broader societal places in which trauma shows up and is amplified. And one is, as I mentioned, historical trauma and structural racism. And certainly COVID-19, even before the murder of George Floyd, pulled back the veil on what I call it the way too late great white awakening to the structural racism that has been in our society for 400 years. And historical trauma is this idea that when there is community level or society level trauma, or trauma of a particular racial or ethnic or cultural group, it can be transmitted from one generation to another, but it's not destiny. Healing and recovery are possible, and I'll come to that shortly. I also wanted to add that we've seen over the past year, and this apparently has happened in other pandemics over the course of human history. A pandemic is terrifying for everybody. We never know who's going to get sick and who's going to die and how bad it's going to be and how much loss there's going to be and if and when it's ever going to stop. And so historically with other pandemics, we've also seen blaming the people who got sick or who died and scapegoating one group or another. And we've seen this in particular with the ways in which Asian American Pacific Islander peoples have been blamed in such horrible and violent ways. And then I wanted to mention the masks and cover-ups. You may not remember this, but up until I think April 28th of 2020, the CDC was saying masks don't make a difference, we don't need masks. And you may also remember that that was a period of time where there were not enough masks to be had, and there was a lot of struggle between the states and the federal government about where they're going to come from and who's going to supply them. And then I think it was April 20th, April 29th that Anthony Fauci announced we now have the science that says masks really make a huge difference. And the science has only continued to go in that direction. But unfortunately, because of the limitations of the science at that time, the material limitations in masks and the fear that if the world knew masks really mattered, there would not be masks for healthcare professionals who really needed them. And then the politics, it really interfered with trust and created, I think, this fertile ground for even more trauma for so many of us over the course of this past year plus. And then I wanted to mention specifically for COVID-19, and this is not news to anybody either, physical distancing, which now we're able to, we're seeing changes in with vaccinations. But during so much of this year, when there were so many deaths, and when there was one death in one family or one neighborhood or one community, there were usually multiple deaths that people couldn't come together and do what people have always done, which is to hold each other, to touch each other, and to break bread together. And so just to sort of lay out, not to bring back bad memories, some of the ways in which the specific ways in which the COVID-19 pandemic has traumatized us and made it hard to heal. And then contact tracing, which no one's talking about very much anymore. But when it was a focus, as much as it was really critical to tamping down the spread of the virus, there were many communities in which social networks are held as a kind of private thing because external surveillance has been used to harm communities or harm neighborhoods. So just to sort of see how complicated it's been, that some of the measures and some of the ways in which the measures have played out and the material resources, the way the science has evolved over time, and science always evolves over time. We never know the whole picture, and sometimes we get it wrong, and we have to correct ourselves, as well as the politics have really contributed to the ways and to the effects of this traumatic event of the pandemic. So when you're looking at children and asking yourselves how the pandemic may have led to traumatic effects, you can focus on these 4 functional areas that we've talked about: family relationships, peer relationships, and I touched on self-regulation when I talked about attention and concentration and focus. So to look at the extent to which a child is experiencing changes in these areas. I also talked a little bit about changes in mood, so impulse control, frustration tolerance, and then there are strengths like perspective taking and being able to understand and constructively express emotions to look at to get a sense of how a child is coping during this period. And all of those, self-regulation, executive function areas impact how children learn. And I did want to point out here that without wanting to minimize the extent of learning loss and the racially and class-based inequities in learning loss, where learning loss has been far worse for children who have not had access to digital learning opportunities and have had other material interferences with being able to learn, without wanting to minimize that at all, to also say that children are wired to learn, and they're always learning something. And I worry that we aren't also asking children, well, what did you learn this year? And we can listen to what they didn't learn. And that's my reminder that I'm almost, it's time for me to start wrapping up. In addition to what they didn't learn and what they didn't have access to and what was hard, what did they learn? And there's been some initial exploration of that. And, you know, I think children are very interested in telling us, well, this is what was really different this year that I discovered. And, you know, being able to think about where strengths are and where the positives are is not a Pollyanna-ish or a denial exercise. It's a way of creating safety to then enter into the things that are harder and scarier and more painful, to be able to first also conjure up some of the things that represent strengths and are not so upsetting. So here are some common behavioral and functional manifestations of COVID-19 in children. Again, no surprises here, but I will say that you know, looking at this research back in the summer and looking at it again just over the past couple of weeks, it's still very early on. A lot of it's conflicting. The studies are limited because people are trying to find out what they can quickly. So there are from many different places in the world that have experienced the pandemic at different points in time in different ways. The ages of the children are often different, but here are some of the basic kinds of things which again aren't surprises: anxiety, behavioral discontrol, trouble separating, declining academic functioning, learning loss. We talked about depressive symptoms, fearfulness, reduced life satisfaction, regression from behaviors that were previously mastered, sleep disturbances, and withdrawal from family or peer relationships. And again, there's the other side where, you know, there's a significant minority of kids who are saying they're doing pretty good or better, and you know, there's some kids and parents who are saying we're not going back to school. We're gonna try to figure out how to do the homeschooling thing. And I don't mean to put that on a pedestal, but just to try to lay out the complexities of getting a sense of what this is really looking like and the individual variations. So as we now begin to wrap up by thinking about what we all can do, I wanted to share with you, I'd shared with you SAMHSA's 3 E's. Here are SAMHSA's 4 R's. For trauma-informed care, there's realizing the widespread impact of trauma and potential paths for recovery, recognizing the signs and symptoms, not just in patients and families, but also in staff, in ourselves, in our institutions, and responding by fully integrating knowledge about trauma. And I hope I've been able to offer you a little bit, not just into our clinical work interactions, but into policies, procedures, and practices, and then actively seeking to resist re-traumatization. And again, I want to go to racialized trauma, because that is one area of trauma that happens, can happen multiple times every day. Just thinking about common places where re-traumatization is going on. So Santos also identified 6 key principles of a trauma-informed approach. Safety. And, you know, this has been a challenge in the past year, but in general, when there is trauma, the first thing that we need to do is safety, and we don't want to be putting someone into therapy or some kind of treatment if they're still, you know, being hurt. But in the real world, and in this real world we've been in this past year, that's not entirely been possible. We've talked about the critical importance of trustworthiness and transparency. We've talked about the really powerful protective effects of relationships, including with peers, collaboration and mutuality, the sense of we're in this together, this sense of being able to have voice and choice and feel like I can act on the situation in a positive way where I have some value. I told the story about that patient of mine who was able to make masks, and then to look at the cultural, historic, and gender issues with regard to where the vulnerabilities are, but also to where the sources of healing are. So to focus on healing for a moment, to think about it as a process. I don't think that there's an endpoint. I don't think that there's closure, but it's a process where disruptions in health and well-being can be repaired, where capabilities and functions can be recovered. And although, you know, none of us would ever wish any kind of trauma on anybody, there are ways in which growth in the wake of a trauma can build new strengths that we might never have had or known we would have. So over time, with healing, we can't erase it, we can't forget it, but we can actually remember, understand, and as we remember and understand and tell the story in new ways, we can reduce the distress that it brings up for us. And again, this process of remembering and understanding in new ways can help us uncover and expand strengths that we might not have known we had. So resilience is this idea of being able to bounce back from challenging events or experiences that people on, but it's not a trait that some people have and some people don't. It is, as I said earlier, evolving and dynamic. And there were moments for all of us where I think we may have thought we were resilient, but feel like we're just not bouncing back right now, or we may not be bouncing back for a while. So it's been misunderstood as a trait that some people have and some people don't, which I worry about a lot, because I think there's kind of blaming the victim in there. So think about instead as this dynamic process that all of us have more or less access to at different points along the way that depends on our personal strengths that are not always accessible to us, like being able to be flexible in our thinking. When we're scared, we can't think flexibly often, but when we're more reassured, we can. And also being able to look at the same situation from different perspectives. So again, those kinds of things that help us be resilient are available to us at some times and not others. And then there are life conditions that may come and go or may be constant that support resilience, like, as I've said, close and caring relationships with at least one trustworthy adult who consistently offers unconditional acceptance and encouragement. Those are really the foundations for resilience, but it's not a trait that some people have and some people don't. So ways to heal, I said, establish safety. Medication, psychotherapy can really help, but I wanted to emphasize that a lot of healing can actually be about building back the rest of who we are. So one of the things that I've worried happens is that when treating someone who's had trauma, their identity gets sort of hunkered down around the thing that happened to them. And all of the other things that they are lose focus. So I think a lot of the supports for healing are about, well, who else are you? And what else do you think about? And where are your passions? And what are your competencies? And what are your aspirations? And building up those then helps return when the memories come up to understand and rethink what happened in ways that reduce stress, as I said earlier. And that is, that kind of building out the rest of who we are is a kind of reclaiming of our relationships, of our communities, of our soul, of our bodies and minds, of our self and identity. By retelling our story, I'm not just going to let myself be reduced to the thing that happened to me. I don't have damage etched on my forehead. I reclaim my sense of purpose, and I am able to care for others. And sometimes people say people go into the caring professions do so because they're trying to take care of themselves. That's okay. That helps us heal. And then power, reclaiming the power for advocacy and movement building to stop the sources of trauma, including racialized trauma that we've experienced or that others experience. So reclaiming, renaming, retelling, reaffirming, self-determining, healing can look like reclaiming the story that we tell about what happened and about who we are and the world that we live in. And I think of it as a kind of spiral, because this is not a straight line where things are getting better one step at a time. As life goes on, there will be moments, as I said, where there's a trigger. It's that time of the year, the weather a certain way, we hear a song, we see a person who reminds us of, or there's a new traumatic event, and it brings us back to what happened. But I think it's really important to understand that whenever that happens, it's hard, it's painful, it's scary, and it can feel like we're going backwards. But each time that happens, and think about children as they develop, but adults too, because we're always developing, each time that happens, we bring new experiences, new expertise, new capacities, and for children, new developmental capacities when we get reminded or triggered to reclaim, rename, retell what happened in ways that are less blaming of ourselves, are more hopeful about what the future can be in the world that we're in. So it's a spiral where we're not going in a straight line up and up, but where we're circling back to re-experience at times, but to bring new experiences and new capacities to learn and grow and heal. Not erase, not forget, but to learn and grow and heal. And I just want to share with you that some of that approach actually comes from indigenous ways of healing, and this is a list of indigenous projects for healing from historical trauma that comes from the Maori scholar Linda Tuhiwai Smith's book, Decolonizing Methodologies. You can see storytelling, celebrating survival, remembering, and lots of creative sorts of activities are among the ways of healing that she names. And these are not typically things that we're writing on a prescription pad. And yet, when you talk to people who have experienced trauma, they will often tell you these are the kinds of things that have helped them reduce their distress and move forward with their lives. So what children need now are the truth, and that's been not always available. They need consistency, predictability, and clarity when we can. And even when we don't know, when the science is unclear or we don't know what's going to happen, we can be clear that we don't know and honest about it. We need to recognize what they're going through, and we need to honor their determination to get through it, even through their times of hopelessness. We need to model, as I said earlier, how we handle the fear, uncertainty, unknowns, and need to model the resourcefulness that helps us get through. And children need to have this sense of purpose and value too. They need opportunities to help. It's not, some people talk about it as parentifying children, but I think we overplay that. Children, even very young ones, really feel better when they feel like they can be a part of the solution. And finally, children need us to take care of ourselves. And for those of us who are in the healthcare professions, we're really focused on taking care of other people, and we may be more comfortable doing that, and it may be a lot harder for us to stop and authorize ourselves to take care of ourselves. And it's also hard, obviously, when people are working double or triple shifts because there aren't enough staff to take care of all the people who are sick with COVID. So I don't mean to make it sound like it's always easy or available to us materially. So caring for ourselves, I talked about vicarious trauma at the very beginning. Here are a few ways to do it. To think about why you do what you do, about your gift of compassion. Let yourself accept the limits of what you can do in the caregiving work that you do, and recognize that when you may be feeling like you can't do enough, that the supportive relationship you bring and whatever kind of health caregiving you do may be far more healing than you think. And you may just want to ask your patients about that someday if that's a surprise to you. And then I think to pause and recognize that we actually get to do deeply meaningful work. My daughter is a pediatrician, and she said to me a couple years ago, you know, I feel really lucky, Dad, because I don't have to ask myself every morning when I wake up why I do what I do. And then to seek connection and comfort in our own relationships, all ways of caring for ourselves. So trauma-informed equity approaches to healing start with safety, focus on justice, recognizing that we're all in this together. None of us wins alone. We all win together. And really lifting up strengths, protective factors, the ways in which we can get to resilience, the power of relationships to heal, and the healing that lives inside cultures. And I'll just close with this quote from W.B. Du Bois' book, The Souls of Black Folks. This is from the last chapter called The Sorrow Songs. And I don't think I have to say much about it except to say humans have been through all kinds of horrendous, unthinkable, inhumane traumas over centuries, and yet people, groups of people, cultures find ways of holding on to their strengths and transmitting them over generations so that they can protect their children and not just survive, but recover and thrive. Thank you very much. I think we may have time for a couple of questions.
Thank you so much, Dr. Sparrow, for an insightful presentation on this very important topic. Unfortunately, we don't have time for questions. We are running out. We have a lot of questions. We had almost 200 attendees. I will ask only one. You mentioned what children need now more than before the pandemic. And we know that there is a challenge transitioning back to normal. So I'm wondering if you have any recommendations for, transitioning back to the new normal for parents and families. If we could answer this question. And for the other questions I got through the chat, the answers, many answers are in your slides, and we could share some of the questions with you via email and provide our participants, more information via email. I'm sorry for running out of time, but this was a very interesting presentation. So any recommendations for, transitioning back to a new normal?
Well, for before the pandemic, when we talked about children who were beginning school, say beginning kindergarten, there were a series of recommendations about making that transition gradual and making it relationship-based. And so we may want to take what we've learned over decades about how to help children make a transition, say, from preschool to kindergarten, and apply to the situation. And most important are the relationships. So particularly during this period where people have been, terrified and experienced losses and not know what's going to happen next, being able to reconnect with the teacher that the child will have in September, a personal connection will be really important. And if they're going to be going back to school in person, especially for younger children and children who are older, who may be starting middle school or high school, who've not yet been to that facility, to get to check it out physically before they go. So it's really breaking it down into smaller steps. But the other thing that I think may not be satisfying to people if they want a quick and simple one-size-fits-all answer, but to really listen to the child and to look at some of the individual differences that I tried briefly to touch on. There are children who are outgoing and gregarious and have been missing being with friends, may have a really easy time. They've been dying to get back to school and to be with other kids. And they may pretty quickly not look like they've been through a lot of this. And there may be some children who have those kinds of temperamental characteristics, but who've had a serious loss, the what, when, where, who that I pointed out. They might be a gregarious, extroverted kid, but if, a grandparent died who they were close to, it may look very different. So I think looking at each child through, I think the kinds of individual differences that I tried to lay out to understand what they're going to be ready for, what's going to be hard for them. And then, children who are, tend to be shy and quieter and, are slow to warm up and are less comfortable with change, this is going to be harder for them. And then kids who experienced either bullying or racialized bullying in school may really not want to go back again to that. So I think the recommendations are not one size fits all. Listen to the child, look at the who, what, when, where of what they've been through and their sort of individual characteristics to get a sense of what kind of preparation they're going to need and how much of that kind of breaking down into smaller steps they're going to need. But I would put the relationship with a teacher, and if possible, and if safe, given COVID-19 vaccination status, with some of the other children who they will be with or back with if they go back to school in person in the fall.
I agree. I totally agree. Thank you so much. That's all we have time to answer today. Many thanks again to our speaker, Dr. Joshua Sparrow, Monica Smith, who is handling the technical backend of the program, and to all of you who join us today. Just a reminder that in about an hour, you'll receive an email with a link to a post-program evaluation. Your feedback is important, so please take the time to complete. Certificates of completion will be sent via the email you provided on the evaluation, so please check to make sure it is correct and should be received in 1 week. A calendar of the partnership's upcoming virtual programs can be found at our website, partnershipmch.org, under the Professional Education tab. We also offer on-demand recording of many of our programs, which are listed there as well. Thank you, and we hope that you can join us at our next educational event. Thank you. And now to Marie Carr.
Thank you all for joining us. Thank you, Dr. Panetti. Thank you, Joshua Sparrow. We do apologize to Dr. Lamacchia and you all for our technical difficulties. His remarks will be on the web, so if you had not had the opportunity to see the entire presentation, please make sure that you log on and complete that. We appreciate your attendance today at our annual general meeting. We look forward to having you join our meetings in the future, join our website, and look at our webinars that are there for your perusal, for your education. We look forward to you joining our fight and aligning yourselves with our mission. Thank you so much for joining and have a wonderful day.